your answers as you listen. At the end of each test, you will be given 2 minutes to check answers. Part A. In this part of the test, you hear 2 different extracts. In each extract, a health professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Hiromichi. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning.
Good morning. What's your problem?
Well, doctor, I feel like suffocating whenever I lie flat on my back. I have noticed that whenever I would recline backwards, I get this feeling, and the problem has worsened recently. I'm now sleeping in an upright position.
What's your age?
54, doctor.
You had any surgeries earlier?
No, doctor.
Do you get chest pain?
No, doctor. I get frequent urination and shortness of breath.
Do you have any sort of bleeding disorder?
No, doctor.
Have you suffered or are you suffering with any other diseases?
Yes, I have type 2 diabetes mellitus, hypertension, asthma, and high cholesterol.
May I know if there is any family history of diseases?
Well, my brothers had prostate cancer, and my father had brain cancer. My brothers and sister have diabetes.
Okay, what medications are you taking?
I am taking glipizide, 5 milligrams twice a day, metformin, 500 milligrams twice a day, Atacand, 16 milligrams daily, metoprolol, 25 milligrams twice daily, Lipitor, 10 milligrams daily, pantoprazole, 40 milligrams daily, Flomax, 0.4 milligrams daily, Detrol, 4 milligrams daily, Zyrtec, 10 milligrams daily, Advair Discus, 100 over 50 micrograms, 1 puff twice a day, and fluticasone spray, 50 micrograms, 2 sprays daily.
Are you allergic to any medication?
No, doctor. Extract 2. Questions 13 to 24. You hear a physician talking to a patient called Mackenzie. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, doctor.
Good morning. Have your seat. What's your problem?
Well, I have a 2-year history of small cell lung cancer that has metastasized in both femurs, lower lumbar spine, and pelvis. I had numerous chemotherapy and radiation treatments and just completed a series of 10 radiation treatments for pain relief. But I have persistent pain symptoms, mostly in my low back and on the right side radiating down the back of my right leg to knee. I have some numbness in the bottom of my left foot and some throbbing pain in the left foot at times. The pain worsens with prolonged sitting in a car, walking, or standing.
Well, what is your age?
I'm 45, doctor.
You had any surgery?
Yes, a chest port placement.
What medications are you taking now?
Duragesic patch, 250 micrograms total. Celebrex, 200 milligrams once daily. iron 240 milligrams twice daily, Paxil 20 milligrams daily, Neurotonin 300 milligrams 3 times daily, and Percocet. I am also having warfarin 1 milligram daily to keep my chestport patent.
Do you drink or smoke?
Yes, I smoke 1 pack a day, and it has been the same habit for about 30 years, and I drink beer approximately twice a day. Don't know when I started that.
Well, the neurological examinations show that reflexes are 2 plus in both knees and absent at both ankles. Sensations are decreased distally in the left foot, otherwise intact to pinprick. Examination of your lumbar spine shows normal lumbar lordosis with fairly functional range of movement. There's a significant tenderness at your lower back lumbar facet and sacroiliac joints that seem to reproduce a lot of your low back and right leg complaints. The multiple scan reports reveal that abnormal uptake involving the femurs bilaterally. You have increased uptake in the sacroiliac joint regions bilaterally. MRI of the lower hip joints shows heterogeneous bone marrow signal in both proximal femurs. Pelvis CT shows a trabecular pattern with healed metastases. CT of the orbits reveal a small amount of fluid in the mastoid air cells on the right. You have small cell lung cancer with metastasis at the lower lumbar spine, pelvis, and both femurs. Symptomatic facet and sacroiliac joint syndrome on the right, and chronic pain syndrome. Peripheral neuropathy of your left foot is probably secondary to the chemo and radiation treatments. I will plan on injecting your right sacroiliac and facet joints under fluoroscopy today. If the pain is persistent even after this injection, you can take an extra 50 microgram patch and take a couple of extra Percocet if needed. From now, you stop taking Paxil, and I am planning to start Cymbalta instead. That is the end for Part A. Now look at Part B.
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer, A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at question 25. You hear 2 doctors discussing the topic of keeping the immune system under control. Now read the question.
Doctor, could keeping our immune system under control be as easy as managing our diet?
Well, for instance, the immune cells involved in multiple sclerosis mainly depend on sugar to activate the disease. However, the common drug for multiple sclerosis, dimethyl fumarate, blocks this energy pathway. Contrarily, these energy pathways are feasible targets to treat certain diseases that might extend to dietary measures. I'd like to be extremely cautious about this because nowadays diseases and diets have become very common. However, the theory that energy metabolism is crucial in the way the immune system reacts suggests that there are possibilities that different kinds of diets are going to have impact on our immune system that we're just starting to understand but are yet to understand it completely. I wonder at some stage if the autoimmune diseases like multiple sclerosis may include diet as part of the disease management strategy, as well as other diseases where immune system and energy metabolism are essential, such as cancer.
Question 26. You hear physicians discussing the topic of coping with a peanut allergy. Now read the question.
Hello, doctor. What should parents do as peanuts have become an allergic substance nowadays?
It is really a very frightening factor to know that peanuts can cause allergic reactions, with increasing reports of sudden death in children following peanut ingestion, and new products are being launched on the market to help parents stave off a peanut allergy in their children. What I feel is feeding peanuts to children doesn't require any specialized products. Right now, we have the strongest evidence that kids are at high risk because they have a severe egg allergy or eczema, and the dietary guidelines suggest that infants with severe egg allergies or eczema should intake peanuts as early as their 6th month. What I feel is introducing peanuts to infants with moderate or mild eczema or egg allergies in a developmentally and culturally appropriate method would probably help prevent peanut allergies for the rest of their lifetime. Since peanut allergies are increasing rapidly, the early feeding strategy is something that the parents should consult with their pediatrician, as it is one of the best sources of protein.
Question 27. You hear the discussion between physicians on the importance of food challenge. Now read the question.
Hello, doctor. Why are food challenges necessary?
Following the recent death of a 3-year-old child that had a food challenge test, a new study of over 6,000 food challenges done found the safety profile very reassuring. Food challenge tests are the mainstay of food allergy diagnosis because other diagnosis procedures are not that precise. We have blood tests and skin tests for food allergies, which carry a lot of false positives. Therefore, in many instances, we do have to perform a food challenge test when the diagnosis becomes doubtful. There are a number of people walking around with diagnosis of food allergies who are actually not allergic to that food.
Question 28. You hear a discussion between doctors about fake Stop the Bleed kits. Now read the question.
Doctor, how do we get rid of the imitators of Stop the Bleed kits?
Stop the Bleed is a national campaign to increase awareness and provide training and kits to help the people witnessing traumatic bleeding. However, we must be very careful when obtaining the kit for our locality. The genuine kits are really very expensive, that may cost from $50 to $100 depending on the contents. However, there are some counterfeit tourniquets which are knockoff products. I would warn everyone that a tourniquet is meant for controlling acute arterial hemorrhage will cost about $25 to $35. Therefore, if you're getting them for a lesser amount, you probably won't get the best one.
Question 29. You hear a physician explaining to his nurse about causes of obesity. Now read the question.
Doctor, could the bacteria in our guts impact the development of obesity?
We often see children eating the same diet and living in the same environment differ in their weight. I feel that there's an interaction between genes and the bacteria in our guts that may be the culprit. The findings suggest that it isn't just the components of the diet, but it's the interaction between the diet we eat, our genes, and our bacteria in our body. Every kind of different diet would cause obesity in an individual who is predisposed to becoming obese. Certain genes colonized with bacteria that are efficient enough to produce more nutrients for the individual, resulting in obesity.
Question 30. You hear a physician briefing staff about the herpes virus infection. Now read the question.
Typically, the herpes virus infect the genital or oral mucosa. They affect the mouth, causing cold sores or blisters that form on the mouth, lips, or gums. There may be a prodrome prior to the blister development, with a burning, tingling, or itching sensation in the infected. Throughout the lifetime, the virus remains dormant in the nervous system, hence the cold sores which often reoccur in the same part. When it infects genital parts, it is called a sexually transmitted infection. The symptoms are similar to the oral infection of the virus. With the first outbreak, an individual may experience nonspecific flu-like symptoms like swollen lymph nodes, muscle aches, and a headache. There's also a possibility of having the infection without any signs or symptoms.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
I grew up in the Midwest, and my folks had a friend who was a podiatrist, foot doctor. And when I was a little kid, I said, I think I'm going to be a dentist. So this gentleman met me one time at the water ski club we were in, and he said, "What are you going to do with your life?" I said, "I'm going to be a dentist." He said, "Great, why?" I said, "I don't know. It just sounds like a good idea." He said, "Well, why don't you come visit me in my practice sometime and let me show you what goes on?" And I did that a number of times. And then when I went to the University of Iowa, he introduced me to some doctors that were up that direction. And I was just sold. I was enamored by the fact that you can have someone come in discomfort and you can make them feel good on the spot. And I was sold.
Let's go over some chiropractic terminology. People hear these terms, but they don't really know what they are. What are corns?
Well, podiatric terminology is very common, and corns basically are accumulations of skin on the toes. Generally, it's associated with a toe that instead of laying flat is bent. And so what happens is shoe pressure will accumulate tissue. That tissue is called a corn. That, in turn, actually makes pressure on the nerve underneath and is uncomfortable. So most people think a corn is a growth. You kill the growth and it goes away, but it's really the deformity of the toe, generally the bending of the first knuckle in the toe, that is the underlying cause of the problem.
What about a bunion?
A bunion is also a deformity of the foot that happens to be congenital in origin. So a bunion is where the first metatarsal bone in the foot drifts towards the other foot. Now, most people look at a bunion and they see a bump on the side of the foot and they think, I just grew a bump on my foot. But in reality, it's a shifting of bone. And that then is associated with the big toe moving towards the small toe side of the foot. This then accentuates the hammer toes that are oftentimes associated with the corns we just spoke of.
Bone spur?
Bone spurs are accumulation of bone, and these typically will occur where there's traction. For instance, in the Achilles tendon, we frequently see athletes who have Achilles tendon traction type spurs. These project off of the back of the heel bone. And what happens is a runner, for instance, or someone who does a lot of basketball or other court activities, they develop that calf muscle and it gets real strong, but it gets short. And that makes the Achilles tendon pull a little harder on the heel bone. That creates traction, and that traction creates growth of bone. A similar spur is one on the bottom of the heel, which is traction of the ligament called the plantar fascia as it pulls against the heel bone in its pathway going up towards the toes. This is oftentimes associated with a flat foot or also associated with a shortened Achilles tendon.
How can people tell if they have an arch problem?
Generally, you can tell if you have an arch problem by looking at your ancestors, the hereditary nature of the thing. So, for instance, if you have an arch problem, or you think you do, and you just simply have a flat arch, but if you look at your parents, grandparents, or siblings, and nobody has any associated deformities, such as bunions, you generally don't have to worry too much about it. But the easy way to do it is have someone else eyeball you from the back as you're standing barefoot, looking away from them, and look at the Achilles tendon's direction downward. If the Achilles tendon direction downward is pretty much perpendicular to the ground, you generally don't have much of an arch problem. If it deviates outward towards the small toe side of the foot, then you generally know that you have some arch problem.
We've often talked about the shoes that people select, especially women's shoes. What's been your experience about the selection process for shoes?
Well, it's real interesting you asked that, because there's been a phenomenon now, especially in the sports world, where people are going to, in quotes, barefoot running or unconstructed shoe running. And they're thinking this is getting back to nature and so forth. But I've already accumulated a handful of people with metatarsal fractures. The last week I had a young lady who had a 2-inch piece of wood stuck in her foot with a very deep infection that we had to take to the operating room. So as far as athletic foot gear, what we always talk about is get the proper shoes for the proper sport. So for instance, most of us say the word tennis shoes when we mean any athletic shoe. Tennis shoes are specific for the sport of tennis. They're flat. They don't give a lot of arch support. They're not meant to, and they're not meant for running. So if you're a runner, get a good quality running shoe. If you do court sports, basketball or what have you, get a court shoe. Now, women's shoes. Women typically are wanting to wear, especially in their younger years, an elevated heel. If you wear a little bit of an elevated heel, 1.5 to 2 inches, probably no problem. If you have a little bit higher than that and the sole is raised, so you have sort of a platform effect, not much of a problem either. But if you wear in the 2-inch to 3 to 4-inch range, frequently what happens is, number one, you load so much pressure on the front part of the foot that if you have one of those deformities we talked about earlier, such as bunions or hammer toes, you put more pressure on it, you make it grow faster, even though its origin was heredity. Now, the other thing that you do, if you're a woman and you're wearing high heels all the time, is you ultimately shorten your Achilles tendon. As your heel goes up, your Achilles tendon relaxes. Nature doesn't like a void like that, and it will shorten the tendon. That makes it uncomfortable to wear flat shoes in later life.
So that the old expression that we talked about earlier, Jimmy Choo may not be for you. Is that correct?
Jimmy Choo may not be for you, or at least maybe only one day a week.
All right. Tell us about the things that you can do now as a podiatrist that you couldn't do 10, 15 years ago.
You know, it's really neat to watch medicine evolve, and you've seen it in all the fields that you interview, but one of the nicest things we have are these miniature instruments now. So, for instance, again, for the athletically endeavored type person, a lot of people develop bone spurs, as we talked about, around the ankle bone. And it frequently occurs with people who do basketball and other court-type activities. And these spurs in days gone by used to be somewhat disabling, and they used to be a major project to get them gone. We'd have to make a big 3 or 4 inch opening and use hammers and chisels and so forth and take them out and lay somebody up for quite a while. Nowadays we have these miniature scopes. They're 4 millimeters in size. We make a small opening on one side of the ankle. We put a scope in, which is attached to a miniature TV lens. We look at the TV monitor, and on the other side we put little vacuums and drills and suction devices to clean things out. Usually requires only a stitch on each side, and that takes care of the problem. Another one that I'm really excited about is also the use of a scope, and it's also a 4mm scope, and that's for people that have painful heel spurs. So most heel spurs we get better with typical type of treatment known as physical therapy, stretching exercises, orthotics, shoe devices. In those rare cases that people don't get better with it, we can treat this with a scope. I go in with a little 4mm opening, release the ligament known as the plantar fascia. It's literally a 5-minute operation, and the patient walks away. They have a stitch on each side of the heel, and within about 4 days, they can take a shower again, and they're back to their regular activities in 2 to 3 weeks. Another one that we've talked about maybe a couple times before is shockwave therapy. Now, we have ultrasound, which is the physical therapy type thing where you put a sound wave on someone and you warm up the body part. But we have ultrasound now so powerful that it can fracture kidney stones. In kidney stone removal, it's called lithotripsy. In the foot, to remove the effect of bone spurs, it's called shockwave therapy. So essentially, a large machine is utilized, and it is applied to the area where the bone spur is, and it literally dissolves the problem.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Hello, doctor. Can you explain how vulvovaginal candidiasis infection occurs, its symptoms, and its treatment?
Vulvovaginal candidiasis is a syndrome rather than an infection, and diagnosis of vulvovaginal candidiasis does not rely on clinical or laboratory criteria alone, but a combination of these two. Usually, vulvovaginal candidiasis is caused by C. albicans, but can occasionally be caused by other Candida sp or yeasts. Typical symptoms of vulvovaginal candidiasis include vaginal soreness, pruritus, dyspareunia, abnormal vaginal discharge, and external dysuria. However, none of these symptoms are specific for vulvovaginal candidiasis. About 75% of women will have at least one episode of vulvovaginal candidiasis, and 40 to 45% will have 2 or more episodes. Based on clinical presentation, microbiology, host factors, and response to therapy, vulvovaginal candidiasis can be classified as either uncomplicated or complicated. About 10 to 20% of women will have complicated vulvovaginal candidiasis, requiring special diagnostic and therapeutic considerations. Types of uncomplicated vulvovaginal candidiasis are sporadic or infrequent vulvovaginal candidiasis, mild to moderate vulvovaginal candidiasis, likely to be Candida albicans on immunocompromised women, Complicated vulvovaginal candidiasis are recurrent vulvovaginal candidiasis. Several vulvovaginal candidiasis, non-albicans candidiasis, women with diabetes, immunocompromising conditions, debilitation, or immunosuppressive therapy. By the presence of symptoms such as external dysuria and vulvar pruritus, pain, swelling, and redness, a diagnosis of Candida vaginitis is suggested clinically. Signs include fissures, vulvar edema, excoriations, and thick, curdy vaginal discharge. The diagnosis can be made in a woman with signs and symptoms of vaginitis when either a Gram stain or preparation of vaginal discharge demonstrates budding yeasts. Pseudo-hyphae, hyphae, or a culture or other test yields a positive result for a yeast species. Use of 10% KOH preparation in wet preparations improves the visualization of mycelium and yeast by disrupting cellular material that might obstruct the visuality of yeast or pseudo-hyphae. Examination of a wet mount with KOH preparation should be performed for all patients with symptoms or signs of vulvovaginal candidiasis. For patients with negative wet mounts but existing symptoms or signs, vaginal cultures for Candida should be considered. In case Candida cultures cannot be performed, then an empiric treatment can be considered. Identifying Candida by culture in the absence of signs or symptoms is not an indication for treatment, since approximately 20% of women harbor Candida sp and other yeasts in the vagina. However, postcoital testing for yeast is not approved by Food and Drug Administration. Culture for yeast remains the gold standard for diagnosis. Vulvovaginal candidiasis can occur concomitantly with sexually transmitted diseases. Most healthy women with uncomplicated vulvovaginal candidiasis have no identifiable precipitating factors. Short-course topical formulations effectively treat uncomplicated vulvovaginal candidiasis. The topically applied azole drugs are highly effective than Niacin. Treatment with azoles results in relief of symptoms and negative cultures in 90% of patients who complete therapy. Over-the-counter intravaginal agents clotrimazole, 1% cream, 5 grams intravaginally daily for 7 to 14 days, or clotrimazole, 2% cream, 5 grams intravaginally daily for 3 days, or miconazole, 2% cream, 5 grams intravaginally daily for 7 days, miconazole, 4% cream, 5 grams intravaginally daily for 3 days, or miconazole 100 milligram vaginal suppository, 1 suppository daily for 7 days, or miconazole 200 gram vaginal suppository, 1 suppository for 3 days, or miconazole 1200 milligram vaginal suppository, 1 suppository for 1 day. Teoconazole 6.5% ointment, 5 grams intravaginally in a single application. Prescription intravaginal agents butoconazole 2% cream, 5 grams intravaginally in a single application, or turconazole 0.4% cream, 5 grams intravaginally daily for 7 days, or turconazole 0.8% cream, 5 grams intravaginally daily for 3 days. Turconazole 80 milligrams vaginal suppository, 1 suppository daily for 3 days. Oral agent fluconazole 150 milligrams orally in a single dose.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.